Okay. Thank you. So as mentioned, the title of this talk is PET-CT-based dosimetry for yttrium-90 DOTATOC treatment of neuroendocrine cancer. I'd be remiss if I didn't mention that this is largely Mark Madsen's brainchild, and he was unable to come, so I'll be presenting on behalf of Mark and really the rest of the University of Iowa team. This project is entitled Image-Guided Diagnosis and Therapy of Neuroendocrine Tumors. It's an NCI, National Cancer Institute funded project, and we use gallium-68 DOTATOC to determine eligibility of patients to receive 3 therapeutic cycles of yttrium-90 DOTATOC. As you're all aware, the kidneys are the critical organ, and they limit the amount of Y90 DOTATOC that can be safely administered. We're using the standard 23 gray limit. And it was the major goal of this study. We had a lot of talk about personalizing. We wanted to personalize the therapeutic yttrium-90 DOTATOC dose to each patient based upon the measured radiation dose to the kidneys from the previous cycle administration. So we are personalizing. This is largely a nuts and bolts talk about how we did this and the results. We actually used 2 different kinds of imaging for this. We used imaging with Bremsstrahlung SPECT CT. We can image the actual distribution of the yttrium-90 DOTATOC with this methodology, but as Bremsstrahlung is polyenergetic, it makes quantitation, absolute quantitation, difficult. Relative quantitation is possible, certainly with this, but we can't really tell how many megabecquerels are in the kidney at any given time. However, we can do that with yttrium-90 PET-CT, and so we can image and directly measure yttrium-90 DOTATOC concentration and activity with PET-CT. Just by a bit of review, Y90 is actually a good agent for this. It has a half-life of 64 hours. This is all review for you guys. It emits endpoint energy 2.28 MeV beta. It averages about 1 MeV total. But it is high enough energy that it will cause Bremsstrahlung interaction with nuclei of atoms in tissue and produce sufficient X-rays for SPECT imaging, so we can image the kidneys directly with this. And also, most importantly, it also has this quite rare 34 out of a million decay pair production, where it creates pretty much an electron and a positron out of nothing, but the positron annihilation gives those 2 511 keVs that we can image with the PET-CT scanner. And I would be remiss if I didn't mention this was all the result of work that Jerry Nichols did back in 2004 as a trained nuclear physicist. He saw this quite rare decay and decided to test to see whether PET could in fact image this. He presented this back at IEEE back in 2004, and it's one of the reasons this is actually moving forward. Here are our methods. This is how we functionally went through our kidney dose estimation. First, we had to do the eligibility scan. We had to make sure that the patients had tumors that were adequately somatostatin receptor positive. Following that, we did the standard amino acid infusion, protect the kidneys. We injected, in all cases, virtually all cases, a standard dose of 4.4 gigabecquerel on the first cycle. And after that first cycle, we then proceeded to do the kidney dose measurements, and based upon that, we either injected more or less on the following in an attempt to get as close to 23 gray to the kidney as possible without going over, although we did have a limit of 5.6 gigabecquerel as the highest, just 20% higher, as this is largely, amongst other things, a safety study. In general, we did the amino acid and then the yttrium-90 injection. We waited usually about between 5 and 6 hours before we got them on the PET-CT scanner. We imaged in a single bed position for on the order of 30 minutes to get sufficient counts. And immediately following the PET scan, we brought them upstairs to SPECT CT, and we did a SPECT CT scan functionally at the same time point, between 5 and 6 hours. We brought them back the next day at 24 hours for a SPECT CT, then at 48 hours for another one, and at 72 for another, so we can get the kidney clearance. So in the end, we ended up with a plot of kidney activity with personalized dosimetry data. It was all normalized to the absolute activity that you got from the PET data, and then we scaled the decay that we saw from the SPECT data to match the single 5.5 hour data point that we got with the PET. Once again, nuts and bolts standpoint, this is the general workflow. Here's how we did the image analysis for the PET scan, the PET CT. First, what we had to do was segment out the kidney. Radiation dose is energy deposited to the kidney per mass, so we needed to do that quite accurately. So we, from the CT, segmented out in 3D the kidney itself. That's the inner circle, the inner volume of interest that you kind of see. And then for the PET scan, we actually expanded that kidney volume of interest that we drew on the CT by about 1 centimeter in all directions. We found empirically, based upon phantom studies, that if we did that expansion by about 1 centimeter in totality, we would capture virtually all of the yttrium-90 activity that was in the kidney. The SPECT analysis was functionally the same thing. We had those 4 data points, and we drew regions around the kidneys. We co-registered, drew regions around the kidneys in all 4 of those. From that, we ended up generating a plot of kidney counts, and these are in arbitrary units here, for the 4 data points from 5.5 hours up to 72 hours. But then you remember that we also took at 5.5 hours that PET scan, which we actually isn't an arbitrary unit, it's in megabecquerels. And so what we did was we scaled the SPECT curve to match the PET at that 5.5 hour time point. You integrate under this and you get total counts, and from total counts you can calculate the total dose. I'm going to spend a couple of minutes on this. Here's the results of 21 patients that went through and completed all 3 cycles. What you can see in this first column here are the cycle 1 administrations, which was 4.4 gigabecquerel pretty much across the board, except for patient 2 and 28. Those were pediatric, so they had their own protocol. That's why they're a little bit less. You can see, and we'll follow through, just to understand these, we'll follow through just 2 patients. We'll follow through the first one, and we'll follow through the third one. So the first patient got 4.4 gigabecquerel, and if we go over to this last column here, what you see is cycle 1, which is this blue bar here, ended up giving about 11 of the 23 gray available. So we clearly couldn't give 4.4 gigabecquerel each time, or we'd bust over the 23 gray to the kidney. So we had to drop in the second cycle down to 2.7. We did another imaging, PET, SPECT, CT, etc. When we measured that, we found we got up to about 16. That left us about 7. So on the very last one, we were able to bump it back up a little bit. And then we kind of hit the wall at the 23. But that's kind of the way we adjusted it. Now on the flip side, if we look at patient number 3, we started with that same 4.4 gigabecquerel, but you end up seeing that we only gave about 3 gray to the kidney. So we bumped it up as much as we could, and the protocol would allow to 5.6, and lo and behold, we got functionally the same amount of dose to the kidney, another 3, and then we gave the max again. So in the end, we gave maybe 9 gray to the kidney. This is a patient who clearly would have benefited with more dose from a therapeutic standpoint if the protocol allowed. But there's a wide variability between patients. Some we made it all the way to 23. Others we wish we could have done more. What we see here in the center is the kidney dose per activity injected. The blue bar on the top is for the first cycle, and the kind of tan bar on the bottom is the second cycle. You'd like to see, well, physicist in me would like to see them being equal, but sometimes they go down, sometimes they go up. We understand, I think, why they go up. I think the majority of the time because of the treatment effect. But the bottom line is, it is frequently different each time, so we do have to make measurements at each time point, each cycle, in order to get good results. The problem is that this is difficult from a clinical standpoint. It's difficult from a patient standpoint to have to come on really four successive days for the 3 successive days for this imaging. But what we did do is we observed that the slow component clearance from the kidneys had about a pretty constant 35-hour half-time, and it was fairly constant across subjects. So the question is, could a single measurement be sufficiently predictive to estimate tumor dose so we wouldn't have to do the patient coming back and doing all these SPECT CTs? So I'm not going to go into grisly detail about this, but I will tell you where we've gone. So what we functionally did was we modeled the kidney clearance here as a bi-exponential. And if, in the end, if you integrate that to get the total decays, you find what you can get in the numerator is the kidney concentration at a time t, let's say 5.5 hours, which, by the way, is exactly what the PET scan tells you. So we get this, and then you have this kind of complicated term at the bottom. The interesting thing is this complicated term down at the bottom is fairly constant across patients. So we just actually have a number that we have the PET data multiplied in concentration multiplied by constant, which is what we have plotted over here on the right. So here we have the kidney activity concentration. That's the PET measured volume of interest, microcuries per cc. And then if you just kind of read up, let's say they had 8 microcuries per gram here, then you just kind of read up and you can find, oh, that's about 8 gray. This is a remarkably linear relationship, a great correlation coefficient. These dotted lines are about plus or minus a gray, which is probably well within the experimental error of the measurement. And so it looks at least promising that we might be able to simplify this and make this a much easier thing to do practically downstream. What we're doing for the kidneys, we can also do for tumors, as long as it's within the field of view. We do the same thing as long as we can delineate the volume. We can do the volume, we can measure the time course, we can integrate under the curve, and we can get counts, and we can measure the dose to the tumor from this as well. In conclusion, bottom line is there is sufficient yttrium-90 signal to quantify the kidney uptake with PET-CT. We do that pretty well. It looks like we're going to need to get the kidney dose assessment for each cycle, for each time point, because it does seem to change from cycle to cycle. The single yttrium-90 DOTATOC PET study, as opposed to the PET followed by the SPECT CTs 3 or 4 times, may be sufficient to estimate kidney dose with enough accuracy to determine treatment administration. Fourthly, the method for estimating kidney dose can be applied to tumor dose if we're lucky enough to have it in the field of view. And lastly, and perhaps most importantly, this is a general methodology. It's likely applicable to other targeted yttrium-90 label therapeutic pharmaceuticals. Thank you very much.
Thank you, John. The paper is now open for questions. While any people go out, maybe we'll start with, can you detail a little bit what is the procedure for PET? How long does it take to acquire the PET images, and are these done with time of flight or?
Yeah. So this was done on a Siemens MCT. It was done with a time of flight. We did not use the resolution recovery on this particular data set. We acquired in a single bed position for 30 minutes for it.
Thank you. So please state your name and institution, please.
Roel Valkma from Rotterdam. These 3 times 4.4 gigabecquerel yttrium DOTATOC is familiar. It's coming from the phase 1 trial that we performed about 15 years ago. We then also investigated which kidney dose would be tolerable. And the very old 23 gray, which comes from external beam radiation therapy, proved not to be consistent. So we turned it up to 27, but our final analysis, which was published in a special issue in, I think, 2006, that most people could tolerate far more, except those with diabetes and hypertension, or a combination of both. So why are we still lingering on the 23 gray limit?
So that's a good question, and the answer is we have an extremely conservative clinical team. This was first and foremost, though, a safety study, and so we were starting low, and we were going to be measuring this and also looking at, I didn't mention it, but we're looking at long-term kidney toxicity. We're looking at creatinine. We've seen nothing. Everything has been fine, as one might expect. But this is an early phase 2 I will say in the eyes of the clinical investigators here. I agree, and I think the answer is probably even higher than 27 personally. But I was not involved in the design of this.
All right, one more question.
Wittgenstein from the Royal Melbourne Hospital. How did you factor out the amount of radioactive urine in the calyces, or did you just include it in the kidneys?
So that was a good question. That's a very good question. You don't want to measure the stuff that's in the collecting system, and when one does do the expansion of that volume of interest of the kidney, first the kidney we avoid the collection when we do the kidney the kidney volume itself, number one. Then we expand that by 1 centimeter, but then in particular, if we see there is activity in the collection, then we do modify that volume of interest to avoid where the urine happens to be in the collection system, because that does impact it quite substantially. And in fact, that nice line that I showed did have some outliers, but it was, the outliers happened to be in cases where we didn't effectively exclude the very anatomy that you're talking about. And then when we did exclude it, then the linearity maintained. So you do absolutely positively have to be careful about that. And you can see it on the PET images.
All right. Thank you very much, John. We now invite the next speaker.